Hello, this is Rebecca Circa, and this is a case study about urinary tract infection treatment that addresses antibiotic usage in the lactating female. The patient is Betsy. She's 30 years old. She comes in with a chief complaint saying that she has been experiencing burning with urination for 2 days, looking for medication, but she's concerned because she is still nursing her son. Her history of present illness, she states that she's been having painful urination for 2 days and that she has been drinking more water, but the pain is not getting any better. She also states that she's been having more frequency and urgency. For subjective data, Betsy takes a prenatal vitamin every day. She also uses an albuterol inhaler, 1 to 2 puffs, as needed for shortness of breath and wheezing. She's allergic to pet dander and dust and pollen. She has a past medical history of asthma when she was diagnosed at age 8, and she had an appendectomy at age 14. Her mother is 53, still living, and is diagnosed with hypothyroidism and takes medications. Her father is 56, living with asthma, and uses an albuterol inhaler as needed. Her sister is 27, living, and has obesity. Betsy is married with 2 children, ages 5 and 18 months. She works part-time at a local business as an accountant. She denies tobacco use, is not exposed to secondhand smoke. She drinks 1 to 2 glasses of wine several times a month. She denies illicit drug use, consumes 2 cups of caffeinated beverages per day, and for exercise, she runs several miles 2 to 3 times per week and states that she maintains a healthy diet. For her review of symptoms, she denies rashes. She denies shortness of breath. Her last asthma attack was 6 months ago, in which she was effectively treated with her inhaler. She denies any recent cough. As stated before, she's complained of dysuria for 2 days. She's also had frequency and urgency. She does deny hematuria, denies back pain, and denies any history of kidney stones. She denies abdominal pain. She denies nausea and vomiting. Her last menstrual cycle was 1 week ago. She denies vaginal discharge. She is still nursing her 18-month-old son 1 to 2 times per day, mostly at bedtime. She states that she sleeps 5 to 6 hours per night and denies recent weight loss or gain. For objective data, Betsy is sitting comfortably on the examination table. She's well groomed and she seems reliable. She's answering questions appropriately. Her skin is warm, dry, intact, with no evidence of rashes or wounds. Her abdomen is soft, non-tender, with no masses. She has no evidence of cough or shortness of breath. Her lung sounds are clear. For her GU system, she has malodorous, cloudy, dark yellow-colored urine, which is positive for nitrates in the office. She is afebrile. Her heart rate is in the 60s. Her blood pressure is 121 on 78. She's not requiring oxygenation, and her SATs are 98%. She is 60.8 kilograms and 175 centimeters tall with a BMI of 19.9. So in ruling out and diagnosing Betsy, I asked the appropriate questions to rule out STI at this time, and based on her assessment findings and her positive nitrate findings in her urine, would be diagnosing her with a urinary tract infection. Pathophysiology of a UTI is a colonization of in the vaginal tract by ascension of uropathogens, mostly gram-negative, from the fecal flora into the urethra, and also that travels into the bladder. This can cause inflammation in the bladder wall that stimulates stretch receptors, which contribute to urgency and frequency. Prostaglandins are released from the mast cells which contribute to inflammation and can produce pain. They can also cause hematuria, as there's an increased vascularity in the urinary tract as prostaglandins are released. Common pathogens that cause UTIs, the main one is E. coli, accounting for 75 to 95% of infections. Other pathogens that are found in UTIs are Proteus mirabilis, Klebsiella pneumoniae, and Staphylococcus saprophyticus. Risk factors that contribute to UTIs for patients is that some patients have altered bladder epithelial cells that allow for the bacteria to adhere to the bladder mucosa, which can be a genetic factor, or patients that are immunocompromised can have defective epithelial cells in the bladder. Also, patients that have residual urine in their bladder after voiding presents bacterial washout, which needs to occur with urination. Pregnancy can also be a risk factor that contributes to UTIs, as there is increased pressure on the bladder, and the increased estrogen has also been found to contribute to UTIs. A lack of estrogen has also been found to contribute, and so there needs to be a balance there. Incontinence is also a risk factor, as well as any foreign objects like catheters, spermicide, diaphragm use as well. Increased sexual activity in the female is also a risk factor, and it's recommended that the patient void 10 to 15 minutes after intercourse to prevent infection. For antibiotic therapy options, there are several to choose from. The first line choices are Bactrim DS, which is a combination of trimethoprim and sulfamethodoxazole, as well as Nitrofurantoin. Other drugs that can be used to treat UTIs have been the fluoroquinolones, such as ciprofloxacin and levofloxacin, the beta-lactams, such as amoxicillin, cephalosporins like Keflex and cefixime. There are many reasons to use different antibiotics. Some choices are eliminated due to allergies, of course, and the reactions that patients may have with their current medications. For Betsy, I'm going to be exploring the two first-line choices that are recommended by the Sanford Guide and some of the up-to-date references that I found. It was kind of difficult to choose between the two of these, and I'll explore these next. The first drug that I explored was the Bactrim DS. The dose recommendation for this medication to treat UTIs is 1 tablet PO twice daily for 3 days. This is a combination drug with the trimethoprim and the sulfamethodoxazole. These are not commonly found apart. They can be used separately, but the combination has been found to be very effective to treat UTIs. This is only a 3-day treatment, which is usually better for patients the shorter they have to take the medication. This works as a bactericidal. It inhibits folic acid synthesis in the bacteria. It's metabolized in the liver and excreted by the kidneys, and the half-life is 6 to 10 hours. As Betsy was pretty concerned about safety in lactation for her child, the recommendations I found that it's not recommended for high-risk infants less than 1 month old, which would not be applicable to her son as he's 18 months, or patients with hyperbilirubinemia or glucose 6-phosphate dehydrogenase deficiency, which also does not apply to her son. Of course, I would caution Betsy that any antibiotic that she takes can be excreted in the breast milk and can cause diarrhea in the nursing child. So I'd caution her just to look for signs of this while she's on the treatment. Common adverse side effects of Bactrim include nausea, skin rash, hepatitis, and Stevens-Johnson syndrome. If she had any history of elevated liver enzymes or any reaction before, I may caution her that a different medication would be helpful. Currently, the cost for this drug is $4. It's on the $4 list for 10 100 milligram tablets. Second choice that I could use for Betsy would be the Nitrofurantoin. The dose recommendation for this drug is 100 milligram tablet twice daily for 5 days. This is also bactericidal and alters the bacterial ribosomal proteins, leading to inhibition of protein, DNA, RNA, and cell wall synthesis in the bacteria. It's metabolized in the liver, excreted in the urine and the bile. It's absorbed in the tissues. And this drug has increased bioavailability with food intake, so I would encourage Betsy to have food while she takes this medication. The half-life of this drug is 25 to 60 minutes. In terms of the safety in lactation, I found that the relative infant dose that is excreted in the breast milk is 5%, and anything less than 10% is considered safe for the child. So that would be safe for this child. It was also found that any infant less than 1 month old or patients with, again, glucose 6-phosphate dehydrogenase deficiency would not be recommended to take this drug, which again is not applicable to her son. And again, GI upset or diarrhea is a risk for the child when they are breastfeeding. Adverse side effects of this drug include brown-colored urine, allergic reaction, nausea, and peripheral neuropathy. The cost for this drug currently is between $20.36 and $44.16 for 14 100 milligram tablets. So for Betsy, I had a tough choice as both drugs were safe for her child and both drugs were relatively safe in short treatment. However, I chose Bactrim for this patient as it was more affordable and the length of treatment is shorter. So the chance of her following the recommendations more closely would be easier for her with a shorter treatment. A couple of things that I would caution Betsy to look for while taking this medication is that Bactrim has been found to have a higher resistance. So I would encourage her to take the medications as ordered and to not skip any doses if at all possible. Even if there's usually found that patients start to have relief between 24 and 48 hours after starting the medication, so I would really encourage her to make sure she took all of the doses. Because Betsy has allergies, environmental allergies, and allergies to pollen, I would caution her that she has an increased risk for allergic reaction to this medication, and so I would really encourage her to call me if she did have any signs of allergic reaction, that she may need a different medication for her treatment. So my plan for Betsy, again, is to educate her to finish the entire course of the antibiotic treatment. I would encourage her to consume at least 8 glasses of water daily. There are some findings that have been used commonly for educating patients with UTIs that have been found to be inconsistent, yet wouldn't harm the patient if recommended. So Cranberry extract or cranberry juice, like I said, has been inconsistent in the findings, but has been found to be bactericidal in some cases, so that may benefit her. Also, the balance of maintaining at least 2 liters of fluid has been found to be helpful in flushing out the urethra. Excuse me. I would suggest that the patient watch her caffeine intake, as that can be diuretic in nature, and so I would just caution her while she's taking the medication to possibly decrease her caffeine intake. I would suggest that the patient take a probiotic while on the Bactrim to prevent any GI upset or diarrhea that can be found from antibiotics. I would also recommend that the patient use a dependable birth control while on the medication. Has been found that some birth defects can occur in the early stages of pregnancy while on the medication, so I would encourage her to take a dependable birth control. Also, I would have the patient avoid spermicide and diaphragms, as those are risk factors for UTIs, and in fact would encourage her to also avoid after intercourse to prevent any infection there. I would send her urine sample for culture to see what specific bacteria was growing and also check for sensitivities. If the patient had any sign of an allergic reaction, or if she was not getting better on the treatment, I would have her return and could possibly change her to the Nitrofurantoin, as that's also a first-line treatment recommendation. If Betsy, she did complain of some burning with her urination, if it was significant, I may recommend that the patient take phenazopyridine, 200 milligrams, 3 times a day for 3 days as an analgesic to help her with pain relief. These are my references, and that is my case study. Thank you.